And I chose this topic because I wanted to learn more. I mean, it's so much going on in the world of myeloma with novel therapies and various things that is going on. But I wanted to see how those were affecting the Black community. Are we taking advantage of those newer therapies? Are we doing as well with those newer therapies? So hopefully these doctors are going to give us some answers here today. Dr. Blue, many of you know Dr. Blue. He's been with us a few times. He's an assistant professor at Moffitt Cancer Center in Tampa, Florida. His clinical interests include treatment of plasma cell disorders and evaluation of patients pre and post bone marrow transplant. His research interests include reducing health disparities and improving health outcomes of plasma cells dyscrasias. Dr. Blue recently completed a blood and marrow fellowship and cellular immunotherapy fellowship at Moffitt Cancer Center. He completed an internal medicine residency in the Department of Medicine at Washington University School of Medicine in St. Louis, Missouri, and a hematology oncology fellowship in the Department of Medicine at St. Louis University School of Medicine. He earned his MD at Meharry Medical College in Nashville, Tennessee. Shakira Grant is an assistant professor of medicine at the University of North Carolina, Chapel Hill. She holds a dual faculty position in both the Linebarger Cancer Center's Division of Hematology and UNC's Division of Geriatrics. Her research is focused on aging-related vulnerabilities and how they impact the health outcomes of older adults with myeloma and other hematological malignancies. She is one of the few hematologists, oncologists, geriatrians in the country and a leader in the field of geriatric hematology. Dr. Grant served a fellowship at Fred Hutchins Cancer Center at the University of Washington and a residencies at the University of Pennsylvania in Philadelphia and Queen Elizabeth Hospital in Barbados. She earned her medical degree at the University of West Indies in Barbados. Now, it's my pleasure to introduce you to Dr. Raleigh Fatoki, Dr. AO, as he prefers to be called. He recently graduated from his internal residency at Kaiser Permanente in the San Francisco Bay Area. He then made the big move to Miami, Florida, for a fellowship at the Hematology Oncology Center and Sylvester Comprehensive Cancer Center with a special interest in myeloma. He will be sharing more of his story as part of this presentation later today. So thank you all three for attending today, and we're looking forward to an incredible session. Dr. Blue, the time is now yours.
Thank you so much. So today I really wanted to just take some time to talk about hope, right? So really, I think a lot of people who are listening, may have a diagnosis of cancer or may have a family member with a diagnosis of cancer. And when you hear those things, sometimes hope is one of the things that really just, your cup may not be full at this time. And so one thing that's specific about multiple myeloma is that unfortunately, we have not found that cure quite yet, right? But I wanted to just kind of let people know about some of the things that we have that are coming down the timeline so that you can potentially put some nuggets in your hope jar so that not all hope is lost. Okay, and so hopefully I'm able to communicate that today. Hopefully we can get some good discussions and people can talk more about kind of what's next, what's happening, and I'll be happy to talk about it in much more detail, okay? As Valerie mentioned, I'm here at Moffitt Cancer Center that's in Tampa, Florida. I did do a fellowship in both bone marrow transplant and what they call cellular therapy or immunotherapy. So, really I knew that that's where myeloma treatment was going. That's where cancer treatment is going. And I wanted to make sure that I was an expert and a specialist in those things. So I wanted to just kind of let people know the timeline of how things happened in myeloma. So for example, you can look back 20 years ago, for example, okay? And just know that if you were diagnosed with multiple myeloma in 2003, okay, there really weren't many options. That was just around the time that we really started to develop one of the main drugs that we have now called bortezomib, or some people may know it as Velcade. Okay. Really, over the past 20 years, as you can see, the different treatment options have really exploded. Okay. The things that we have available, even if you go back 5 years, is much more than what we had. And so, what we always tell people is that the future is bright. What we always hope is to keep that same momentum so that the next 20 years can be even better than these, and that we can continue to improve upon and add medications to and get approvals for people with that condition. Okay. Now, one thing I will mention is that you can kind of see where even in some years, multiple different drugs were available even in that same year. So even waiting 6 more months, 12 months, some period of time, a new treatment was available. A new treatment was available. If you talk to some of your other friends with cancer, or if you look up other cancers, that's not the case for all cancers. So really, myeloma is special because really the amount of treatments that we have, the speed at which those treatments are becoming available is something that many cannot say is happening for their type of cancer. So that will make the future bright, I guess, in my mind. But the big problem with multiple myeloma, as everyone can tell, is that it's not quite curable yet. So, what does that mean? That means that once someone has a diagnosis of multiple myeloma, they unfortunately go through emotional roller coasters, but they also go through physical roller coasters. And really, they experience this up and down and up and down of diseases doing wonderful and I'm doing great, or now my disease is back up again. And so, really, one of the main things that we hope to do with this cancer is really try to figure out how do we keep this thing down for good? How do we put a lid on it so that we can prevent those ups and downs? Okay. The problem is that myeloma is so complicated. It's not one thing that is driving those cells to kind of reactivate or what we call relapse. So even though sometimes it can be months or even years in between those times that the disease decides to come back, unfortunately, we do see it time and time again. Another thing to know that everybody's an individual. So you might talk to some other myeloma person. You might say, well, this person's disease has been under control for 10 years. What's different about mine that I'm only getting 6 months? And it's unfortunately because the myeloma is so different, it makes it very difficult for us as the doctors and even us as the researchers to try to figure out something that's going to work well for everybody. So just know that it's not from a lack of trying or that your doctor did something wrong. It's just that's just how myeloma is from a disease standpoint. Okay. And so that's important to know. It's also important to know that we've kind of moved into this era of what we call immunotherapy when it comes to myeloma. So, what that means is that traditionally we used to give medications called chemotherapy that sometimes can be a little bit harsh on the body. However, now we figured out a way to kind of use the body's immune system to be able to attack the cancer cells. We said, well, what the heck does that mean? Your body, my body, and everybody's listening body, we have what they call an immune system. You say, well, what does it do? The immune system is really there to protect us, protect you from COVID, protect you from the flu, protect you from whatever is out there that could potentially hurt you as far as, infection related. So these, soldiers is what I call them. These soldiers are used to fighting. They just used to fighting off, bacterias or viruses and things like that. So luckily, we came up with the idea to say, well, let's have these soldiers just fight cancer since they're so good at getting rid of things. And it turns out to be remarkable. It originally was approved for a different type of cancer called leukemia and lymphoma, but we've been able to modify that same technology to actually have it work for multiple myeloma. And so far, we've seen some excellent results. So I just want to let you know that this is really where the future is heading. And really, we got to be smart about it, because what we had been doing even 20 years ago, it's helped tremendously. We've made great improvements. But again, I think we're all looking for that cure. And in order to do that, we got to do something out the box. We got to do something original. We got to do something what they call new and innovative. So just know that the name or the title that has been given to these immune system related cells is called CAR T cells, all right? That may be a word that you may have never heard before, but just know that it's called CAR T, and it's an abbreviation. Everything in medicine is an abbreviation, but it's chimeric antigen receptor T cells. And I know it's a mouthful, but it first got approved back in 2021. So it's really not that old of a treatment, okay? And the thing about it is that as we talked about going up and down and up and down on the treatments, it was one of those things that got approved after you've had 4 different treatments, okay? So after you've seen medications like lenalidomide or pomalidomide or bortezomib or carfilzomib, after you've seen daratumumab, all these medicines that, you may be receiving earlier in your disease, after those things unfortunately have stopped working, the question is, well, what's next, right? And this is really the treatment that should be what's next, okay? There was a big trial, everything happens through research, and we found out almost 75% of people, if you give them this, will respond, which is fantastic, okay? So just like, the old TVs. I don't know if people are on here are old enough to remember this, but the old TVs that used to kind of sit on the ground and, you have to, get some pliers to turn them and those kind of things. We've made big advancements. Now you have a television right on your phone that can fit in your pocket, The same thing happens with CAR T. So the second CAR T that got approved, we think may even work a little bit better than the first one. And we'll continue to make some improvements as time goes on. People seem to think, again, that the people that respond to this second type of CAR T is about 97%, compared to about 75%, which is fantastic, right? I mean, that's really, you want something that not only will work, but traditionally we can give you some type of durability. And according to the study that they did, they said that almost 70% of people at 2 years really still were alive and doing okay. So, we appreciate that because, we want to be around and have as many birthdays as possible. And so it looks like even after some of those more traditional medicines have stopped working, these new and improved CAR T cells is what they call chimeric antigen receptor T cells. It's a mouthful, but basically it's these things that your immune system can do to fight off your cancer. Again, like I said, there's kind of the original, and then there's the volume 2 or version 2. They use words like Abecma, Carvicti. You might see some of these names. The names don't necessarily matter as much as to what it's doing, okay? So meaning that we see that these different treatments are able to push the disease back sometimes a year, sometimes 2 years. And really, once you've seen a lot of those different medicines and drugs, pushing the disease back even 6 months is a big deal, because unfortunately, as the disease evolves, sometimes it just becomes more and more resistant. So the fact that these medicines are working so well in people that have seen so many different drugs is really a game changer. So then we didn't stop there, right? So, somebody at some point looked at, all the different cars that were out and was like, let me make a motorcycle, something that works similar, but just a little bit different. And that's kind of what we did as well with this. So instead of having what they call a CAR T cells, we developed something called a bispecific antibody. And really that just means that we use technology that basically was able to hold on to a myeloma cell and one of those soldiers and say, look, the myeloma cell and the soldier, y'all go ahead and basically connect at the hip so that you can't get away from the soldiers. If he's going to kill you, you're not getting away. Okay. And it's a way to bind that together to make sure that the soldier really can kind of have what we call sustained killing, because it is good for the medicines to work, but it's even better when the medicines work for a long period of time. And so this just became available right around Thanksgiving. So, it hasn't been that long as well. And again, in that same population of people who've seen a lot of the more traditional medicines, the lenalidomide, the pomalidomide, the daratumumabs, when all those medicines have stopped working, we have this medicine called teclistamab, which is again a bispecific antibody that really does a fantastic job of killing cancer cells. Again, we look, well, how well will it work? They saw that what they call the overall response rate, or how well does it work? About 63% of the time. Again, this is still fantastic. There's no medicine that we have on earth right now that's going to work in 100% of people. Okay. And so what we try to do is really help as many people as we can with as much treatment as we can. And just know we're not done there. There's more on the way, okay? All the medicines that I just talked to you about today, they use a target on the myeloma cell called BCMA. Not necessarily important to remember, but just know that they all use the same target. Now, as we all know, myeloma is smart, and myeloma tries to do something and change every once in a while. So we have actually other targets available. So then the thought will be, at some point, do we use one target? Do we use two targets? What happens if we combine the targets? That's where things are heading. And that's really where it's going to get exciting, because we have so many tools in our tool belt that we know if A works and B works, God only knows what happens when you combine A plus B. And so we're just hoping that at some point we get to that cure. I wanted to briefly just discuss what the heck happens with the CAR T, because people get super confused. So here at Moffitt, we do a lot of CAR T. I imagine where a lot of people you are, especially at these big centers, they do CAR T. If you go to your doctor that is in what we call the community or in a smaller doctor's office, they're not probably going to have this available. But in most of the big centers throughout the United States, they have this available. And it's something that if you've been on a lot of different treatments and they're wondering what's next, it's something to really consider. The issue, though, is that even if you come to the big city and somebody says, hey, I think you're good for CAR T, there is a little bit of a wait time, meaning that if you come and see us in February, the CAR T process may not happen until March or April. Okay, because we have to collect those cells. Okay, the cells that we use to fight off the cancer, we have to collect them through a process called pheresis. All right. After we collect them, those cells get shipped off across the country. That process takes about 6 weeks. Okay. And then they come back to us here well, at least here in Tampa, or back to the center. And then we have to admit you to the hospital. You get chemotherapy to make sure that your body can basically receive those cells. We don't just take them off the plane and give them to you. So it's a process, but it is an important one, and one that we know does work. Okay. So just know that we try not to wait till the last minute and say, oh my gosh, somebody really needs these CAR T tomorrow, because it just doesn't happen that way. Okay. But we also would love to see people whenever we can to not only give them education, but to let them know that, hey, this CAR T can really help. Now let's converse that or compare that to that other medicine that we talked about, where it's called a bispecific antibody. Because this is really like a medicine, all we really need is a bed in the hospital and insurance approval. So that's about a week. Some insurances here or there, can take a little bit longer, but it takes about a week to kind of make sure that we can get this medication in you. And then once you're here for about another week. And you say, well, why do I have to be in the hospital so long? The reason is because these antibodies can create almost like like flu-like symptoms or things like that, where your body is confused and thinking that you have maybe a flu or because your immune system is so activated, you can get fevers and chills and shortness of breath. Sometimes you can get some of these side effects, and a lot of times we rather those side effects happen here at these big centers where we're comfortable and we can kind of take care of it, as opposed to you going back home and then having a 102-degree fever, because that's just nobody feels good when they have a fever like that. And so, those are some of the differences that we have. When I talk about advantages versus disadvantages, everything in life costs money. These medicines cost money. That's just the way life is at this current time in America. So the one thing I will say is that the CAR T, you will need to be at a specialized center. So like if you live in a rural area, or a place that just doesn't have access to that, there's likely, it may be a bit of a drive, but again, there's likely some type of CAR T center in your area. Um, some of the disadvantages, again, like I said, is that it takes a while, so that CAR T isn't available. It's not something I could give you tomorrow. The big benefit, though, is that CAR T is what we call a one-time therapy, meaning that once you get that CAR T, those cells will continue to what we call recruit and divide and add more cells to continue to be functioning later on. When we look at those, what they call bispecific antibodies, again, it's a medicine, so it's right off the shelf. All you got to do is order it from a pharmacy and, we can get it. You know, I will say you have to be in the hospital for about a week, so you have to be comfortable with that. I will say as a disadvantage, and you can call it a disadvantage, but it is continuous treatment, meaning that it's not a one and done. All right. You'll keep staying on that medicine until it's no longer stops working, just like the more traditional medicines in multiple myeloma. So just know that right now there's no like research or data, or there's no trial that compares like this CAR T versus this bispecific. Like we don't have that. So if anybody is like telling you that there's data on that, we really don't have that at this time to say which one is kind of what we call head to head, compare apples to apples, because they're not apples to apples. They're apples and oranges. Sometimes your doctor will recommend an apple, sometimes they'll recommend an orange. Sometimes the CAR T is better, sometimes the bispecific is better. And just know it's super complicated, but just know that we have options. It's better to like have at least some fruit than to be like, oh, should I get the apple or the orange? Just like, look, man, you got fruit, okay? And you got something that potentially can improve and help your disease, okay? And just know that they all are approved by the FDA, all right? I wanted to just kind of leave this slide just to say that, I talked about a little bit, but that's kind of like a drop in the bucket in the ocean, okay? It's so many other things that's coming down the pike that really people should be um, really excited, because the future does look bright, okay? And a lot of them will use kind of some of the same technology, but what we're hoping is that each round gets a little bit better, a little bit better. And there's an old saying that every round goes higher and higher, and that's what we hope and that's what we expecting. And hopefully I was able to shed some light on something that's very complicated, but this is new stuff, hot off the press. And hopefully people have questions for me, or if I could help anybody in any way, I'll be happy to answer some questions.
Yeah, awesome. Thank you, Dr. Blue. You got some good graphics in there. Dr. Cole would be so proud of you. He always gives us some good graphics. So yes,
Yeah.
thank you for that great presentation. Great explanation of the bispecific T-cell engagers there, the analogy of the soldiers. I think that helps a lot of people understand exactly how they go to work in there. So I know we got a couple of questions that we're going to ask there, but one thing that you did mention is, the T cells have to be out, they have to be sent out and remanufactured. Are you seeing any improvements? Because there have been long wait times. Is that improving?
Yeah, as you can see, these things kind of became available during COVID, right? And unfortunately, what happened was that we saw with really everything. If you want to buy a sofa a year ago, they're gonna tell you it's gonna take you like 6 months, 12 months, just to get a sofa. You know what I mean? The same thing happens in medicine, is that the normal processes that we had before COVID of things just being very streamlined, it wasn't happening. Getting new cars off the car lot, they didn't have these little chips in them because factories and stuff just wasn't working like that. And the same thing happened for this. So as I think we come out of the pandemic, as people are getting back to work, as we understand more, so like you got to think these things are new. And so it's kind of like, imagine if you had something that was really hot and like selling like hotcakes, but you had so many people wanted the product and you couldn't keep up. You know what I mean? And that's kind of a similar thing, that as more and more options become available, it won't just be, oh, there's only one type of CAR T, so everybody got to flood and get that one. Now we got two options for CAR T, right? So that means it doesn't have to just be one. And now we have two options for CAR T and then some for bispecific. So so as more and more things come out for people in that group, hopefully that'll decrease the demand and that'll decrease those wait times. But yeah, it is a problem. It still is a problem, but I think things are getting better.
All right, we're going to go here. So the first question, Thomas asks, what's the status of CAR T for allogeneic transplant patients?
Yeah. So typically, there's two types of transplant. That's what they call autologous and allogeneic. Typically, in most circumstances, for multiple myeloma, we're doing autologous stem cell transplants, where the donor that you have for the transplant is actually yourself, meaning that you won't need a donor. The allogeneic transplant is done in very few circumstances and typically done on clinical trial. So it's not necessarily something that we see a lot in multiple myeloma, because unfortunately, for a lot of people who get allogeneic transplants, sometimes the disease still relapses. And unfortunately, it becomes a problem. So, the thought process is in other cancers, meaning let's just use leukemia, for example. Leukemia, they have these allogeneic transplants, but because there is a chance of cure, it's what we call a high risk and high reward. In myeloma, if the disease is still going to come back, even after such a big allogeneic transplant, then I think that risk benefit just isn't there. So it's not something that we commonly see in myeloma.
Okay. Okay.
Yeah.
All right. Thank you.
Hopefully that makes sense, but if not.
Yes. Yeah. So we have Courtney. She's fortunate enough to have gained a slot for Carvykti.
Oh, nice.
But now she's debating over whether or not to opt for a bispecific over the CAR T.
Yeah.
And she wants to know kind of with that option, what's going to be the best option for her.
Yeah. So, I mean, that's a personal decision, right? Between you and your doctor. I will say again, like I put in the slides, advantages of, CAR T is a one and done, right? So if that sounds appealing to you, of like you go in, you get the Carvykti, and you done for the next, year and a half, or however long, hopefully longer, that's very appealing to a lot of people. Sometimes the bispecifics, again, you have to be in the hospital for a week. Sometimes that's not as appealing to people. I will say that when it comes down to durability and how long the CAR T or the bispecific keeps the disease in control, typically we're seeing longer times for CAR T, but CAR T is more intense. Like what it takes to do CAR T is a little bit more intense. So it kind of depends on, how strong you are, how much you're willing to do. But it's advantages and disadvantages to both. So I can't necessarily say what's best for you without knowing you personally, but that's a great conversation to have with your doctor. And just know that, there are options. Both are probably going to be good, but, there may be one that's better for you personally.
Yeah. So Dr. Blue, is it possible to have the bite therapy after you've did CAR T?
Yeah. Yeah. So again, the one thing that we're trying to figure out is how well that works, because a lot of the studies and things that made those medicines approved, you couldn't have the CAR T available. But I will say that we're trying to figure out data now that if your cancer still has that target, that BCMA that we talked about, if that's still there, then there's potential for the drug to still work. And so I think that's where a lot of the research and stuff is going now. But again, y'all got to think this thing only been out since Thanksgiving. You know what I mean? So, give us a little bit of time so us to figure this out a little bit more. But we're trying.
Yeah, yeah. And just quickly, I want to go back to the allo CAR T. Is that something that is currently done, or are there studies being done on that? Or
Yeah. So I thought that the question was an allo transplant. So that's two different things. So we do have an allo CAR T, but that's currently in clinical research. What we have here at Moffitt is what we call an off-the-shelf CAR. So as I mentioned before, one of the things that makes CAR T kind of tough is that you got to wait, 6 to 8 weeks. So with this new, what they call off-the-shelf CAR, it's a CAR T that we can basically give it to you next week. Okay. The question is, will it work just as well as your own cells? Because it's research, we don't know, but that's what we're trying to figure out right now. Like, how do we make CAR T better? And one of the things that we think might work is, what if you didn't have to wait as long? But maybe it's not better because it's not your own cells, so we don't know yet. But there are clinical trials. But that's for allogeneic CAR T, which is different than allogeneic transplant, which is, it's kind of a whole, it's complicated. But the two separate things. But hopefully, I explained it in a way that makes sense.
yeah. So if a patient has had an allogeneic transplant, are they eligible for CAR T at a later time?
Well, again, like I said, once the disease relapse after you've seen 4 lines of therapy, that's more, it's not necessarily the transplant itself, it's more so the lines of treatment. And so I think that's more so the focus. But again, like I said, the percentage of people with an allogeneic transplant in myeloma is very small, right? So that you would be talking about a less than 1%.
Okay. And Donna
Because the type of transplant that we do for myeloma is what they call autologous. So it's a different process. Yeah.
Thank you for the explanation.
No problem.
Yeah. Are there any VA centers that are currently doing the CAR T therapy?
Yeah, so typically people go to 2 places. They either go to where Shakira trained in Seattle, or they go to Nashville, Tennessee. So those are the 2 places. Sometimes the VA allows these, I forget the name of it. There's some term the VA uses where they allow you to get like non-VA care community. No, I forget what it's called, but there's a term for that where the VA might say, well, you live in Florida. Why would we have you go all the way to Tennessee to get this treatment? You can get done right in Florida, and the VA grants you that, but I don't know about like who in the VA is service connected and some of those kind of like nuances that the VA has. But if you're a person in the VA and it's something that and you have myeloma, your doctor should know about how to get it, because the VA is a very particular system. And we see patients from the VA all the time, but I know they have to get approval first. Like you can't just get it done. But who the VA approves and doesn't approve is a whole system. So, but typically Nashville and Seattle are the big transplant and cellular therapy centers through the VA.
Okay, awesome. Thank you. So is it best to collect the T cells immediately after diagnosis versus waiting?
Well, again, you can only get it collected after you've relapsed, right? So again, that time from needing CAR T to newly diagnosed, I'm hoping it's years. Okay. So, at this point, we're not collecting T cells on people at the very beginning on something that you may not need for 5-6 years. Like that, we just wouldn't have the storage ability to do something like that. But the better question is, will CAR T work earlier in somebody who's newly diagnosed? Now, that is an interesting question. And that's really where the research is going, is what happens, like, if you gave this right off the gate, will it do an even better job of killing? We don't know, but for sure, we're going to try to find out.
Yeah. I know, and I wish that there were more studies on that. I mean, let's get the good stuff up front, not waiting
Yeah,
until
well,
the end.
it's like everything else, though. When the COVID vaccine first came out, we didn't just give it to everybody because that wouldn't necessarily be fair. We said, well, who are the people who need this the most? And we said, well, we needed to give it to people who have cancer, whose immune system is low, people who are elderly, whose immune system is low. We have to make sure that the people who are dying from COVID, got the resources quicker. And that's the same thing. Myeloma has a lot of different treatments. And so we had to prioritize and say, well, this stuff just came out. Who are the people who need this the most? And you say, all right, well, let's give it to the people who have seen all the more traditional things. Let's give it to them. And then eventually we'll work our way up to it because it's already research doing it right now. But again, it just takes time. You know what I mean? And I know we live in that microwave generation where we're ready to boop, 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 make it happen. But, it just doesn't work like that sometimes. So.
Okay. I think you alluded to this a little bit, Dr. Blue, as far as the bispecifics,
Mhm.
is it given after a relapse and after having 4 prior lines? Do you have to, is that the eligibility criteria?
Yep. So after 4 lines, right? So 1, 2, 3, 4 CAR T, 1, 2, 3, 4 bispecific. So it's after 4 lines, yeah.
Okay. All
Mhm.
righty.
But like I said, you can ask your doctor, or there are clinical trials, I'm telling you, that's giving it earlier and earlier. You know what I mean? So don't get stuck on that, okay? Because if you're at a place, I always tell people, especially our Black folks, if we can get in a clinical trial to get something that might help us a little bit sooner, I'm all for it.
Yeah, thank you. Thanks for mentioning that. And then this will be the last one, Dr. Bowitz. It's after having a tandem transplant over a year ago, since I suffer from bone pain, severe fatigue, and brain fog. Is this common? And
Yeah.
any medication recommendations for the pain? And yeah, it sounds
Yeah.
like the side effects are really affecting them, their quality of life.
Yeah, so I'll explain to people what this person has. So they had what they call a tandem transplant. So what that means is not only do they get one of those autologous transplants, but we actually do another one right back to back. And so a lot of times, and it depends on where you are. So not all institutions do this, but some people believe that if you kind of really drive the disease down, meaning that the whole purpose of transplant is to kind of sweep up some of the crumbs, meaning that the first treatment that you had, typically like the lenalidomide, the bortezomib, the dexamethasone, or you may even had daratumumab up front, the whole point of that was to get the disease under control. And then once it got under control, the plan was to sweep up some of the crumbs with the transplant because those crumbs eventually grow to whole loaves of bread, right? And we don't want that to happen. Well, we know it'll happen, but we want it to be a long time before that happens. So we know the fewer crumbs, the longer it'll take. And so in some people, they do 2 of those transplants to try to do a deep clean of that bone marrow. And so unfortunately, with higher risk, higher reward, nothing in life is free, and so sometimes people do get some side effects and some of those kind of things from the tandem transplant. I forget exactly what those side effects you were having are because my brain doesn't remember things too well. But no, just joking. But no,
Fatigue and
you can't
pain.
have some issues. Okay, I don't want to make light of that. I'll say that the brain fog thing is something that can happen, but it's also something that can happen with people just being on treatment in general. So even though people typically get a tandem, they typically may, depending on again your institution, may still recommend you to be on some type of maintenance, meaning that it's not like typically you do the transplant and you're done. And so depending on what they chose for your maintenance regimen, you can be experiencing some issues from that as well. So it may not be, like I said, per se the tandem, but tandem that's literally one of the most intense treatments you can get for myeloma. So but it does have some benefits for people. So unfortunately, it does have some risk as well.
Yeah, hoping that you feel better. I mean,
Yeah, me
that's
too.
got to be so debilitating to go through that.
Yeah.
All right, and I know I said that was the last one, but Janice snuck one in here, so we're going to get this one. It says, if you've been in a long remission for approximately 7 years and you take a medication vacation, when you relapse and only had one line of treatment, can you then choose between CAR T and bispecifics?
No, no, that's what I'm saying. Again, you got to think 1, 2, 3, 4, CAR T. 1, 2, 3, 4, bispecific. And again, that's what we call standard of care. That's what's approved by the government. Okay. I hate to say it like this, but these things are super expensive. That's the only way people can get them paid for. However, if you do a clinical trial, typically these things are covered. So that's where research and those things come into play. So, I mean, I can't tell you about something or what the clinical trials are in your area. However, okay, they're out there. Okay, I'll tell you that for sure because I know we got them here in Tampa. Okay, so if it's something you're interested in, ask your doctor about what clinical trials you can even use some of the resources at HealthTree and really look and get in a community and talk to people about those clinical trials. But what's approved or what we call standard, that's not standard of care, is to after one line do CAR T. I know it's a new hot thing and you're like, I want it now, but again, what's approved, 1, 2, 3, 4 CAR T, 1, 2, 3, 4 bispecific. Okay, so and it's fantastic that you had a long remission. And again, honestly, you may not want CAR T right now. Wait till things continue to get better. Especially if you only had one line of therapy, just keep riding the wave. Okay, and then it's so many new medicines and great medicines that if you haven't been on treatment for 7, 8 years, it's so many things that came out in the last 8 years that you haven't had that still work fantastic. Use some of those things because they're great.
Yeah. I think we as patients, Dr. Blue, we just try to get away from that continuous treatment, the maintenance therapy. If it's something that we can do this one time and be done with it, I think that's what a lot of people think of. Oh, if I do this, I don't have to worry about taking that pill every day or, every 2 weeks going in to get this infusion. So thank you for explaining it like that. That makes total sense now. Very quickly, I do want to ask this. You said all you need is a bed and insurance approval to get the bites. Have you noticed any issues with insurance approval?
I'm fortunate enough to be at Moffitt, and typically most insurances don't tell us no when it comes to things like that because we really try to be the leaders in this field. You know what I mean? And if an insurance typically tells us no, imagine what they'll tell other kind of smaller program. You know what I mean? So we really try to fight really hard for our patients and kind of say, hey, this is approved by the government, because once it's approved by the government, they really don't have a leg to stand on and say, hey, this person has met every criteria that the government said was appropriate for this person to get it. You have to explain not only to us, but to your insurance holder why you're denying them this beneficial treatment. And most insurances, what we call, don't want that kind of smoke. Okay. And so I'm happy to do what they call a peer-to-peer and talk to people as much as I can and tell them and say, look, I'm fighting for my patient. And typically we don't have those kind of problems.
Thank you. Thank you, Dr. Blue, for being with us today. I am now going to turn the program over to Dr. Shakira Grant. And I think before we get started, Dr. Grant has a couple of poll questions for us. So we're going to get those situated.
Yeah, we are. I'm going to just switch over here and show some slides first, and then I'll intersperse the poll questions and really want this to be interactive. So once again, I just wanted to say wonderful presentation from Dr. Blue, and I'm so delighted to be here with you today. As mentioned, I am currently based at the University of North Carolina at Chapel Hill. I am a geriatric hematologist oncologist, meaning that I focus primarily on older adults. And I also have the pleasure of being a clinical researcher, which allows me to really focus my research activities on older Black adults, in particular with multiple myeloma. So before we kind of get started, this is really interactive, just a few slides to highlight some patient-centered quotes, just to highlight the burden of multiple myeloma and some of the challenges that people face with this disease. But I really wondered if we can take just maybe a minute or two, just in just really short words, what are some of the things that come to mind when you think about multiple myeloma? And again, this could be a word, it could be a phrase, and then I'll show you some things that some of our research participants shared, and I'm sure some of these will be very similar to what we see in the chat. So just go ahead, feel free to drop it in the chat box, and we will be able to see those as we move forward. I can also, yes, and thank you so much for saying you can type it right here. Awesome. So I'll let people gather their thoughts. Since I kind of sprung this on you, I warned you that it was going to be interactive. So I see bone pain, incurable, a plasma cell disorder, difficult to navigate, treatable, is a cancer of the bone marrow, specifically in the plasma cells, bad antibodies that grow out of control, cancer, sickness, tumor. So these are all wonderful responses, and there's no right or wrong answer. And just keep those going in the chat, and we'll look at those as we go through today's talk. So in terms of, asking this question, so many of you were spot on with thinking about this. So we asked this question to some research participants here at the University of North Carolina. These are primarily older adults, about 50% of them self-identified as Black race. This one in particular always strikes me whenever I start to read it. It says, I think true myeloma is something that comes in and not only robs you of your physical life, but it robs you of who you are, just who you are as a person, and on many levels of what you were created to be. Another person, which is similar to what we saw in the chat, was that this is intense. It is a painful experience. It's physically limiting and life-altering. Another says it just really can sneak up on you. And I think so many of you on this webinar today probably have similar stories of just not really expecting this, having some symptoms that may have been just non-specific, and just going to the doctor to get this worked up, thinking maybe you're just tired, you're just run down, and then having this diagnosis. And then this participant says to us, I just don't know what to say about multiple myeloma because there's so many issues that are going on. So again, I think these words for me are so halting because as a physician, as a researcher who spends a lot of times with patients, caregivers, learning their stories and hearing their journey, when I see these descriptions, it really tells me just how burdensome this disease could be. So in terms of kind of some real numbers, as you kind of think about this, these are probably numbers you've seen before, but really just to highlight that in all respects, when you compare myeloma to other cancers, this is considered to be a rare cancer. It is ranked about number 14 out of all cancers, but the majority of these cases are going to occur in those who are older, and we define older as being above 65. The reason I show this slide is because this is a disease that really disproportionately not only burdens older adults, but also burdens the Black community in particular. We see that Black patients are twice as likely to get this disease, and yet with all of these advances in therapies, as Dr. Blue has taken us through today, we still see that Black patients are continuing to die at twice the rate than their white counterparts. And while there have been many different explanations, one of the big challenges that we've seen is the differences that exist between Black and white patients in how they're able to access care. And for this, I'm going to pull up a poll at this point and just ask you just to take another minute and just to answer this one poll question. So the first one is, which of the following have you encountered as a potential barrier in accessing care? And then we have a second one. What are some of the ways that providers can build trust among the Black community? So again, just take a minute or two, just no right or wrong answers, and just put your answers in there. You should see it available. If you're having any difficulty, I believe there should be a poll option and should give you that option to vote.
And I'll read them out just while we're waiting there. The first question is, which of the following have you encountered as a potential barrier to accessing care? The first choice, I couldn't pay for transportation to my doctor's office. The second choice, I had no caregiver available to come to the visit with me. A negative interaction with a healthcare team member. Delays in reaching the multiple myeloma diagnosis. And lastly, delays in accessing multiple myeloma care. So those are your choices. If you could click on one of those. And then the second question, what are some of the ways that providers can build trust among the Black community? And the first option is community outreach and education. The second is increase racial, ethnic diversity among providers. And lastly, providers demonstrating care and empathy for their patients. So we'll keep those up there just a little bit longer to give you the opportunity to respond.
Yeah, we still have a couple people submitting, so I'm just going to wait one more minute.
Okay, that is okay. And while we were waiting, I saw some additional answers in the chat and just really wanted to acknowledge them. You know, someone said horrible, challenging, ups and downs, myeloma kidney, uncertainty, affects bone marrow, MGUS as a precursor, MGUS and smoldering myeloma was answered as precursors. And someone lastly said, will I ever not have pain from the last fracture that hasn't healed completely after 2 years? So thank you so much for sharing so openly about what myeloma means to you. Audrey, do we have the answers from our poll? Okay,
Can you see
all
those?
right. Yes, I can. So what we are seeing here is that in terms of access barriers, that the vast majority of people are encountering challenges with delays in reaching the multiple myeloma diagnosis. And this is definitely not uncommon. And I know I probably was a little unfair because I only gave you one option. You could only select one, but there may be some that may be overlapping. And then for the second question about building trust among the Black community, which I think is really important, is that we see here community outreach and education as potential strategies. So thank you so much, and we'll kind of address some of these as we go through the presentation today. So I wanted to again continue because this is really meant to not bring the voice of myself, but really to highlight some of the challenges which are similar to what you explained in the poll. Again, these are from some participants taken directly as they talked about this during interviews with our team. And this patient who self-identifies as white race has said, you know, this is around the idea of delays in making the myeloma diagnosis, which some of you alluded to as challenging. And it says, I had gone for a GYN checkup and I was anemic. And my doctor said, not to worry, you know, I'm getting older. And the patient says, I was 55 at the time. And the doctor said, you're getting older, not to worry, we'll check in 3 months. So we checked again in 3 months and I was still anemic. And I told her at that time, I was quite concerned because that was very abnormal for me. She said, don't worry, you know, we'll check again in 3 months. So in 3 months, I still wasn't any better. And I was fatigued and exhausted and irritable and work was very busy. And so at that time, we decided to go see an oncologist. So I think if I were to even pause here and say to people, how many people here can identify with something like this similarly, I think there will be a few people who would raise their hands, maybe more than a couple. And this is not uncommon with multiple myeloma because of the symptoms that people present with. You can often have these delays where people are just being dismissed, their symptoms are being dismissed as other things, aging related, and not really having the concerns taken seriously. The other quote says, it was really frustrating to know that there was something going on. It was scary for many, many months. All these things kept happening, but nobody could tell me why. I kept having these constant UTIs, which means urinary tract infections. They saw a specialist. And again, it was that same idea. Well, it's just part of getting older. The other that, I know some people voted for this one is, but thinking about the financial concerns, we hear about this a lot. And I think sometimes as providers, we don't always bring this to the forefront when we're seeing patients. We're getting through the visit, we're talking about the labs, we're talking about the M spike, the light chains, what they're doing, what they're not doing, changes in therapy. But sometimes we don't really stop to think about the financial impact of multiple myeloma. And so this one here really says, this really blew me right out to the water, because it said when they sent the prescription, they said Revlimid was going to be about $3,000 or $4,000 a month. Another said, all I know is one of the medications about $17,000 a month. And it's such a scary thing. So imagine you're being diagnosed with this disease, and then you're being told about the costs associated with these drugs. And the thing that has to go through your mind is, how am I even going to pay for these things? The other for this particular quote, and I say this a lot as I present data from our studies, is really to show just how significant the financial implications of having a diagnosis of myeloma could be. In this particular participant who talks about the experience after stem cell transplant, they said, when I came home, my bank account was in negative 656. Right now, it's negative 216. And that was because they deposited $400 in cash. They said, I don't have any money to speak of. And they were just released from the hospital after transplant, and the bank was already calling them. And it was this feeling like they had to beg the bank to understand that they were in hospital getting a transplant for multiple myeloma. And you see how this person is concerned about needing to potentially go on food stamps, and also about whether or not they can have their home in years to come because they're not able to hold down a job because of multiple myeloma. So these are the things that sometimes that we don't think about as potential barriers to cure for patients living with this disease, but really need to come to the forefront. In terms of other things that we think about is these delays that we see between whether or not somebody is diagnosed, maybe from a primary care provider, and then being referred to a specialist. So Dr. Blue mentioned, for instance, going to Moffitt for CAR-T and other cellular therapies. But sometimes it's really in this upfront setting where Black patients in particular are having significant delays when it comes time to actually starting treatment for their multiple myeloma. And that delay is really in the steps between when they start having symptoms and when maybe primary care doctor sees them, and then ultimately makes that decision to refer them for specialty care. So in this particular two participants, they said, they were diagnosed locally on the left, and the doctor locally just said, we'll get back with you. By that time, the patient had decided, I'm going to go seek specialty care elsewhere with a myeloma specialist, and was already planning for chemotherapy. And then on the right, you see here, I would go in every 3 months, again, this delay at the primary care level. And they would just keep, checking the labs. Everything is getting lower and lower, but you're still just checking the labs. And the patient sent the labs to her son, and son said, Mom, I'm going to make an appointment for you. You need to see a hematologist if your doctor can't tell you why your platelets are so low. So you see here that there is really this need for increased advocacy among not only patients, but also patients and their caregivers as you think about these delays and ways in which we can improve these diagnostic delays. The other I'll talk about really quickly is clinical trials. So this is really a large aspect within the Black community especially. And these are some of the numbers that you can see here. On the top, I like to call this the iceberg effect, which is what you can see, the nice white caps, which in this case does not show a good picture. But at the bottom are all of these barriers that exist, especially for Black persons with this disease, that limit their ability to access clinical trials. So you have issues like the socioeconomic concerns or financial concerns, whether or not you even trust the option to participate in a research study. And this is really grounded in a lot of the historical experiences here in the US when it comes to research. The other is kind of individual and systemic or structural racism. So all of the totality of all the policies and decisions that are made that really limit whether or not Black persons are going to be offered a clinical trial option. And then the communication. So, you really value building trust in terms of providers also showing that they care and they're empathetic. And if you don't really trust your provider, then, it's going to be much more difficult to be encouraged to participate in a clinical trial. So this is some of, again, participant voices. Again, I wanted to make sure that this was very centered in participant voices because I think people here will have kind of areas where they can resonate. And this is where we talk to academic hematologists about whether or not, what are some of the barriers to participating in trials. And one thing I will acknowledge upfront is that there's often this idea that even using the word trial could be experimental and it could be negative, and whether we should not be using that word trial and considering using research study as an alternative. And I think that that is a very, very valid point if that word has associated with it some potential stigma. So for this particular academic clinician who was self-identified as white race, they said, I do think there are unique challenges in enrolling Black patients on clinical trials. And this is because of the sordid history of clinical research in that community. Things like Tuskegee experiments are things that a lot of the patients will remember. So there is actually that element of medical mistrust. Here in blue, these are actually patient participant voices, and all of the patients represented here are Black race. And they said, a lot of people my age, they grew up hearing about Tuskegee, where Blacks were used to experiment on through white people. And I really think that right there, in a nutshell, really, really dictates why Blacks are more reluctant to participate in these studies. Another says, you got to present them with something they can get out of it, talking about members of the Black community. And you say, that's just Black people. We just scared of everything. The other that we don't often think about, and, as much as I, as a physician, would love to sit here and say, bias, stereotyping, and discrimination in medical care and research, that it doesn't exist. It would be remiss of me to actually say that. These are all clinician examples of how bias could limit the opportunity to participate in a trial or even be offered in the first place. So this first clinician says on the upper left corner, let's just say poor patients or patients of lower socioeconomic status might not be adherent to all of the necessary requirements of the clinical trial. So that's going to be more of a burden on me. And so I want to put fewer of my less resourced patients on trials. So I know whenever I read this quote, it's often so difficult to imagine that some among us would actually think this way. But this is the reality, and we need to address and confront the fact that there are all these biases that exist. Everyone, as you walk into a room, we have our preconceived notions about others, and it doesn't matter the circumstance. You could think about it outside of healthcare. But really, it's acknowledging these biases and then finding ways to counteract them. Another says there's probably this element that is subconscious bias against Black patients. Another talks about if they're under-resourced, then there's a problem for healthcare in general. So if it's their perception, then they're not going to want to put a strain on that patient on their limited resources. So our participants also offered some potential solutions to talk about clinical trial barriers. And they talked about, one of the ways is to empower patients so that they feel like they can get their questions answered and not be intimidated. Another really just simply stated, if you really want to get access to Black people in general, you need to go to church. The bottom line is every patient needs an advocate. And I think this is so critical. Increasing the awareness when it comes to research studies in the Black community, because of all of the history that has gone on, a lot of it has been negative. And so giving the opportunities to become aware will go a long way, being able to share some of the information so that people will understand it, so that if they're considering a trial in an element of fear, that wall will be broken. And then we talked about something they can get out of it, but I think really important is communication. How are we communicating with our patients, and how are we explaining things, especially when it comes to clinical research studies? And I end with these quotes because as you probably have seen, I am what we consider a qualitative researcher. So I use a lot of patient stories in my talks, in my research, because I believe this is where we can truly understand the true burden of a disease. And I take this quote from Maya Angelou, who says, people will forget what you said, they will forget what you did, but they never forget how you made them feel. And this is some examples of just some of the communications we received from participants in our study, just talking about what a joy it was just to be able to come around and just talk, share their stories and have people listen to them, and then take back what they're saying and actually come up with plans to make action steps. So with that, I really want to thank you, and I'm happy to take any questions.
Awesome. Thank you for that awesome presentation, Dr. Grant. Very good points about clinical trials. I listened to you, Ash, talk about, I think you had the paper, I probably get the name of it wrong, but you have your knowledge, but I have my knowledge of my body, and it talked about some of those powers that, we don't even realize that at that time when we were questioning about a clinical trial, but it's just the power that doctors have over us sometimes that we don't realize. And that causes us to say no, or it really shuts us off from things. So yeah. Awesome. Let's see. Do we have some questions? Let me get it over here. My computer's.
No worries.
Okay. So we have, Yvette has a question here. I think you may have addressed this before you started talk. Will I ever not have pain from that fracture that hasn't completely healed after 2 years?
Yeah, so thank you so much, Yvette, for that question. So I think this is something that patients struggle a lot with, is pain as a result of multiple myeloma, because it's such a debilitating cancer. The time for complete resolution of pain, or even some improvement from where you were baseline, that varies from individual to individual. And so it would be really difficult for me to give you a timeline for that, but I certainly would encourage you to keep that communication open and conversation with your doctor, letting them know about the symptoms that you're having.
Thank you. And this is a good question Yvette has here regarding clinical trials. Since she's concerned, do the trials put you in a situation where you won't get the best care because it's a clinical trial? And I know that's something that a lot of people think about, and let's address that.
Yeah. So thank you so much, Yvette, for asking that question. I think one of the challenges, again, with this idea of clinical trials, and this is where I was alluding to with the language, is that when we talk about trial, I'm going to give my example that I said, if I went to the hairdresser, hair salon, and they're like, well, we don't really know about this style, but we could trial you with this particular one, or we could trial you with this particular product. I think I would have a little bit of pause and be, like, really? I don't know that I want to be trialed on this thing. And I think this is where we can do a little bit better as a community of healthcare providers and everyone involved in these efforts, is to think about the language. So one, Yvette, just because you're in a clinical trial, it doesn't mean that you are actually getting less than less than a optimal therapy. What it does mean, if it's a therapeutic trial, is that most of the time you're actually getting access to drugs and combination therapies that a lot of other people actually aren't getting. The difference comes is that we don't really know how well those particular combinations are going to work. And most of the times they're testing it because they have an idea that it's going to be better than what we actually have currently. So imagine if you are on that arm that you're getting this particular therapy, maybe cellular therapies, the people who got these initial CAR-T therapies in the clinical trials, they have done so well. And so I wouldn't see it as you are getting less than therapy, but I would say you are getting an opportunity to get cutting edge treatments that may otherwise not be available. And then the other thing I would encourage you to think about, because when people talk about participating in research, they always think it has to involve a drug. So I am not a clinical trialist at all. All of the research that we do, and I know there are others out there who do this, we look at things like talking to people to understand their stories, and then leveraging that to actually develop interventions that are community-based to help people access care better, help them with supportive measures. So your participation in research, if you are worried about a drug, you can always participate in studies that are non-drug related, because we definitely need diverse populations and all voices represented. So I hope that answers your question, Yvette. And if any of the panelists also have any other things to add, especially, as you are probably much more involved in traditional clinical trials as this group is thinking of, please step in and add any other thoughts.
Shakira, you're doing a fantastic job. I agree with everything she says.
So Dr. Grant, this is a good question here. When we talk about getting awareness and outreach and things of that nature, what kind of outreach could be more effective other than work in church? Because, that's the first place that we go when we think of outreach. What other places or what other things would you recommend that could be just as effective?
Yeah, so I think that is the $1 million question, right? Is how can we improve our outreach efforts? And I don't think that there is a single thing that we can do, but I think there are going to be a combination of efforts. When it comes to outreach, I do agree that oftentimes partnering with trusted members in the community, which for the Black community often is centered around church-related activities, that is going to be one of the key elements. The other is thinking about other local community resources that they may have where you can go, you can give short community talks, like for instance, senior centers, YMCA. You don't always want to think about only those who are diagnosed with multiple myeloma at this point, but you want to really cast a wide net for people who may not even know what this disease is like. Should they in the future come into contact with someone who has symptoms, they could say, you know what, I remember I went to this thing at the Y and they talked about this disease, maybe you should go get checked. So I think it's really about community partnerships and leveraging those who already have those roots embedded within these communities. And that is a way for us within academic centers to also come to the community and help to build those partnerships, education, outreach opportunities also. But there are various strategies that others have used, but those are the ones that come to mind.
Yeah, I think what Shakira is trying to say is that, us as Black people, we are more than a skin color. You know what I mean? It's a culture thing. What's the culture of a place down in Florida or the Black folks down in Florida? It's much different than the people in North Carolina. So you need somebody who has that pulse on the people. You know what I mean? So like, it's not no, let's just all meet them at church, you know what I mean, and talk to the pastors, because that's way different than even in California where Dr. Fatoki was, like it's just we different people. So I would just recommend if any like pharmaceutical company representative is listening, or any person who's really trying to give some outreach to not only patients with myeloma, but to the community, you should really partner with somebody who have their finger on the pulse of the people, because this is a culture issue, you know what I mean? And so even with, and I know this is not my time to talk, so excuse me for this, but Black people is not a monolithic people, you know what I'm saying? We all are not Southern Baptist Bible people, you know what I mean? You got to think about us in a lot of different ways, a lot of different cultures, because even under the Black umbrella, you'd be surprised how many different type of subcultures that you have, and really you can affect some change in the people if you kind of took that extra step. So I would just be hesitant to be a one size fits all place. And just like Shakira was saying, it's just you got to have, and this is where diversity matters, you got to have some Black folks around you, so kind of what's a no-go, and really where you should go. So that's my 2 cents.
Yeah.
Thank you. Very good point, Dr. Blue. Thank you for putting that out there. It's all about the culture, and not just, we got to step outside the churches. It's a lot in the churches, but it's so much more outside of the churches as well. So thank you. And Maddie, hey Maddie. So Maddie is a support group leader in Philadelphia, and she's working to get some connections at her local church there. And they've been invited to speak at the cancer ministry, and many folks showed up. How would you suggest we involve myeloma specialists like yourself to join in our outreach to this church community? Good question.
Yeah, that's a great question. I would say, I would just reach out to the specialists that you see here. I think Valerie and their team they've done a wonderful job with creating the Black myeloma health community and listing us there as specialists. I don't want to speak for all the others, but I am always happy to help engage or to attend any of these events and to talk a little bit about multiple myeloma. But I'm sure if you reach out to people based on availability, that they will be happy to partner with you. So at least from my end, I can speak with that with confidence.
You'd be surprised how far email will go, and but I would just honestly, I mean, it's so many different groups that are out there. HealthTree is doing a fantastic job, but whatever myeloma community or group that you're affiliated with, they have ties to how to get a hold of us doctors, you know what I mean? And so enough of us are around that we always happy to give these talks, especially the Black myeloma folks. Like it ain't that many of us, you know what I mean? So what we do is we always know that we're the mouthpiece, and we are happy to talk to people, especially our people, because we gotta make sure that our people are dying the most, that they get the most information, and really coming from us, it means a little bit more. And so, we always here to help. And so, yeah, so like I said, any of us will be happy, you know what I mean? Because we do it all the time, and we always happy to do it. And yeah, so Valerie and the team, and again, like that's why she say, you'll see some of the same faces, because it ain't that many of us, but we are always willing to do it. So again, I mean, I got small kids and stuff, but if my time permits, I do it. If my time doesn't, then they plug in somebody else, because we they'll find somebody. You know what I mean? If you really want us to an event, we'll find a way. And especially now, since COVID and stuff is virtual, a lot of us make time on our schedules to really educate the people, because the people is really what matters.
Mm-hmm.
Thank you, Dr. Blue, for saying that. And I'll go back to this saying, I know we often hear this, we have not because we ask not. A lot of times it's just that simple ask. You never know until you ask there. So Evelyn has a great question here. Would you ever enter a clinical trial only when the standard therapies no longer work, or would you enter a trial as newly diagnosed? Good question.
Yeah, so I like to think of this as everybody is eligible for, consider everybody for a trial at any stage of their disease. And I think that is a common misconception where people believe that trials or research studies, I should say, for drugs are only an option after everything else fails. But I would definitely say if there is an option available in the newly diagnosed setting, and it sounds like something, in terms of risk benefits are explained to you, and it sounds like you could potentially be interested, I would consider it also in a newly diagnosed setting.
Can I say something about that? I hope people are listening to this because it's a very exciting trial that's about to open for myeloma in the newly diagnosed setting. So one of the big things that is going to be challenged is the transplant. Do people in myeloma need transplant? So there's a trial that'll be coming out. And again, I'm not sure where everybody's located, but it'll be upfront treatment and then transplant versus upfront treatment and then CAR T. Who knows? I don't know which one is better. You know what I'm saying? But just know and it depends on your personality too, right? Like you might get randomized to the CAR T arm. You like, wait, but nobody's ever done this before. Is this the right thing? We don't know. That's why we're studying it. And for some people that could be nerve wracking, but then for some people they hit a home run and they're like, "Phew, I'm so glad I didn't do what everybody else was doing." So it kind of depends on you and your personality, but it's some things out there that's how we have game-changing treatments, because Revlimid at some point we didn't know worked this well. You know what I mean? And we found out it did. Now there's other drugs called daratumumab and stuff that people are using in newly diagnosed, but we didn't know that was really going to work so well until somebody signed up. The one thing I'll just say is that us as Black folks, we're not signing up. So we need to make sure that it's working for people that look like us and get diagnosed like us, okay? And so that's my 2 cents.
Yeah, no, I love your 2 cents. The example I was going to give is, without doing these trials or research studies in a newly diagnosed setting, we wouldn't be advocating for using daratumumab in combination with Revlimid, Velcade, and dexamethasone, which has really been a game changer, really within the field, in addition to all of the other later line therapies. So I definitely encourage, if there's something out there and you really think, hey, I want to contribute, this sounds like something I will be interested in, to go ahead and give it a shot.
Okay, thank you. Very quickly, I know I missed a question and I want to make sure that we have the opportunity to get that answered. Evelyn had the question, when getting the tandem transplant, would that include the entire process all over, including the melphalan, the collections and things of that? Maybe you can explain that a little bit.
So I think I saw Dr. Blue, he is in the cellular therapy world, so I will let him go ahead with that question.
So I'll just say that typically when we do the collections for stem cell transplant, we typically collect enough for 2 transplants. Like that's typically standard practice in most places. So that the minimum that we need is not what we get. We typically get more than that, typically enough for 2. So the collection process may be a one-time thing, but the actual being able to get the chemo, get the cells delivered, the cells going down, coming back up, that whole process happens twice. So that's why I said it's an intense thing. You know what I mean? Like it's literally probably one of the most intense things you can do. But typically, again, a lot of people think that's high risk, high reward, which is always a possibility.
Thank you for that explanation there. Another question, is there a specific pattern or type of myeloma in the African-American patients that warrant certain therapies versus other therapies or drugs?
Yeah, so that's a really wonderful question. So I think, when you think about differences in why Black persons die at twice the rate than white persons, is oftentimes, people want to explain it by, is there a difference in the disease biology? And actually what has been shown is that Black persons actually have, favorable or what we would call good risk disease in most settings. And so while that does not completely explain the survival differences, I do believe if you kind of look at that particular data, that you will come to the conclusion, which I have, that is not driven by differences in disease biology largely, but really differences in how people are treated for their disease, the time it takes for them to get started for treatments, and then, even things like whether or not they get a stem cell transplantation. So I don't believe that, because of someone identifying as Black race, that we have found that there's more aggressive disease that warrants being treated differently. What we really need to be advocating and pushing for is improved access to timely and quality myeloma related care. So again, I just want to pause and allow my co-panelists to also offer any thoughts.
Yeah, I'll just say that one thing that they did find in the African American community, that we do have what they call a translocation, or a specific genetic marker that we actually have a specific drug for, that's actually higher in the Black population, something called translocation 1114. So it was a national, basically, database registry that they show, well, who has this translocation the highest? And they found that it was actually higher in Black folks. The good thing is we have a drug that actually fits that exact translocation. So, I think this is probably less to do about the biology of the disease and more to do, are you getting the right drugs up front? Are you seeing a myeloma specialist? Are you going to see somebody for transplant? Are you getting the CAR T? Are you getting all this stuff that's already approved from the government, but you're just not going to you? Those are the things that we need to watch out for, and those are the things that we need to improve.
Yeah, thank you. I want to go back. Latasha, thank you so much. You had just a statement up there that you're part of a clinical trial and getting the best treatment, have a great relationship with doctors and the trial team. And you're 1 year, 10 months into a 10-year, a 2-year with 2 months to go. I'm sorry. So thank you for sharing that with us and doing what you can to bring awareness and letting people know that clinical trials do work. So thank you. Thanks for sharing that. Okay, now I lost my place here. Let me get back. Oh, this is a good question here. Are there trials in which patients are compensated to participate in?
Yeah, so again, I will say that there is compensation, but when you think about compensation, you also need to balance that with kind of the ethics, and to ensure that people are not being coerced or choosing to participate in research because of financial gain. So I can't speak for what the therapeutic trial compensation kind of picture looks like, but I do know that in those trials, they would sometimes offset costs like for lodging, parking sometimes. So even though it might not be an actual dollar amount that you get, like a lump sum, there are some things they can do to offset the costs. For the type of studies that I do, and people who tend to do more like patient-centered research, there's usually like just a small incentive. It's usually like a $50, somewhere between $35, $50 on the higher end. It may be $100 for participation in like interviews. But again, this is going to be really, really variable depending on the type of study you're participating in.
And Dr. Grant, that information is provided in the paperwork when it comes to, if they're presented with a clinical trial, all of that information would be in there as well.
Yeah, and that is definitely in there. And I know for sure in terms of like our center here, because we know of the challenges with enrolling diverse populations in trials, there's a lot more efforts on being attuned to some of these barriers, like the financial, like parking and other things that limit people's access physically. And I know there are efforts on the way to try to think about ways in which patients could be at least compensated partly. And some people offer like things like childcare, like if you needed to come in for an appointment, they may give you like the equivalent for childcare. But again, very dependent, and will be in your study paper once you get the consent forms, etc.
Awesome. Thank you for that. Once we have the question, and this is a very frustrating question. I can hear, how is that primary care doctors don't think to run simple protein for Black patients after a certain age, especially with the CBC, CMP, abnormalities or pain. So why not screen? And it's very frustrating because we know it should happen, but it just doesn't happen.
Yeah, I hear the frustrations with not screening. So I think there are two things here. I get asked this question a lot, why can't we just run screening tests for everyone? And I think, I hate to sound like a broken record, but it really comes down to costs. Overall, as I mentioned, the statistics for myeloma, that this is still considered a rare cancer, and the number that we would need to screen, especially if we started screening everybody who was over the age of 65, that would be tremendously expensive, and not likely to potentially yield a significant number of actual multiple myeloma, but rather the precursor MGUS, which is, where you don't have cancer, but this could be watched for many, many years, and most people won't develop myeloma. And so I think it comes down one to that cost issue. But I think also to this question, because I was reading it in the chat, is when people actually present with these abnormalities on the CBC and the CMP, that there needs to be something that is triggered in the primary care provider's mind that to say, let's connect these two dots and not just think this is all age related, or there's not an age-related reason just to have anemia and kidney dysfunction. We have changes that occur, but those two things coming together should at least trigger you to do a check, especially within the African American community, because it disproportionately affects them. But this is where I believe that we need not only outreach to patients, but we also need to be doing due diligence to do outreach to primary care providers and other providers in rural settings that are not anchored to a major academic center where they have familiarity with multiple myeloma. So this really requires a multi-pronged approach when it comes to education and to outreach. But thank you so much for that question. And I agree, we've heard it time and time again, it's so frustrating that people don't connect those two dots and decide to do an SPET, basically.
Thank you, Dr. Grant. And we do have a couple of questions, but I want to be respectful. I want to make sure that Dr. Fatoki has enough time to speak, and we'll come back to those questions that we do have.
Okay.
Thank you.
Yeah, thank you.
So Dr. Fatoki, the time is now yours.
All right, hopefully you can see my slides.
Yep, looks great.
Yes, we can see them.
Wonderful. So, my portion of the talk is about why I wanted to be a myeloma specialist, but what I realized is we're going to touch on many of the topics that Dr. Grant and Dr. Blue have already touched on. But what I'm hoping to do is kind of pull it together from a trainee's perspective so you can see, why physicians get excited and why someone like myself would choose to dedicate my career to this. But before I get started, I just wanted to say thank you to Valerie for the introduction earlier. I don't think she mentioned that I'm originally from Chicago, so I wanted to give my hometown a shout out. But my name is Ayo Fatoki. I'm currently completing my fellowship training in hematology and oncology at the University of Miami. And one of the reasons why I particularly wanted to come to this program in Miami was because of the myeloma program and because of their history of cancer disparities research. And so one thing you'll hear throughout the course of these next few slides is that I'm pretty passionate about myeloma, especially in the Black diaspora. So that's something I'll touch on. But before I get started, I also want to say thank you to HealthTree for putting this together. Not only is this an excellent program, but I really love the organization. And also wanted to just give a shout out to Dr. Blue and Dr. Grant because I really look up to them a lot. I don't have anywhere near their level of clinical experience, but I think the passion and excitement for the field is there. And so I'll be giving you my perspective on why I became interested in myeloma, and hopefully that gives you some insight into why your oncologist may have also chosen their career path. So we'll get into what I love about myeloma, which is the continuity or these long-term patient relationships. Also, the fact that disparities seem to persist throughout the diaspora. We briefly mentioned on tumor biology just a moment ago with Dr. Blue and Dr. Grant, and we stressed the importance of access. But another area that I'm also interested in is studying disease biology with the differences among our Black community. And so I'll get into that. And then ultimately, my final point that I love is similar to what Dr. Blue presented earlier, which is just all the progress we've made over the last 10 to 20 years. And then at the end, I'll give my thoughts on what I'm most excited about moving forward. And again, the goal is to hopefully pick some insight into why we would even choose to focus on this particular disease. Because I think it's one thing to enter the field of hematology or oncology where you're dealing with cancer, but myeloma is special, especially for Black patients and Black physicians. So as we've talked about before, multiple myeloma is currently incurable, and it has complex treatment options. But one of the benefits to me is that though you're stuck with almost well, for the majority of patients, lifelong treatment, the benefit of that is that you end up building really long-term relationships between your physicians or between patients and physicians. And so that's something that I really appreciate. And it's not to say that long-term relationships aren't built in other cancers. It's just that myeloma patients are living longer and longer. And oftentimes your myeloma doc is your only oncologist or your only hematologist, as opposed to other types of cancer where you might have a surgical oncologist, a radiation oncologist, in addition to a medical oncologist. So with myeloma, it's you and me for the long haul, and we figure this out together. And I think from a patient standpoint, you end up having better outcomes. Patients are more likely to show up and more likely to trust the recommendations that their physician is giving them because of this long-term relationship. And I think from a physician perspective, it just makes the work much more fulfilling. Getting to know patients better and better over time gets back to why we got into medicine in the first place, where it's more of a calling and less of a job. It's less transactional, it's more about the people. And so it's unfortunate that we don't have a cure yet. And for many patients, they're on maintenance treatment for a prolonged period of time. But I think that continuity helps both patients as well as physicians. And that's a big reason why I wanted to get into this particular disease field. And so in honor of Black History Month, I felt like it was important to take a moment to define the Black diaspora and how we came to be. And this concept of the Black diaspora is something that's of particular interest to me. So as you can see, I have a foreign name. My father is from Nigeria, and my mom is a Black woman born and raised in Chicago. And so I grew up in Chicago with my parents. And so I was exposed to the African side of the diaspora and the Black American or African American side of the diaspora. But my partner is of a Caribbean background. So her parents are from Jamaica and Grenada in the Caribbean. And spending time with her has exposed me to a whole nother arm of the diaspora, a whole nother arm or group of Black people that I necessarily wasn't familiar with. So you'll hear me talk about, quote unquote, people of African descent. And that's because we're spread throughout the world. And that's a direct result of the transatlantic slave trade. So because of that, there is this shared African ancestry that's spread all over the world. Not only do we have that ancestry or the genetic makeup that's similar, we also share similar culture, similar food, similar language, and those traditions have been passed down for generations. And so we normally talk about the Black diaspora in terms of Black Americans and the Caribbean and Africans, but it's also important to remember that a large percentage of the world actually has some form of African ancestry, and it's not really clear what role this ancestry plays in disease. So when we talk about disparities in the US, poor socioeconomics and lack of access to novel therapies or the standard of care is primarily the main reason why we have worse outcomes. But in myeloma and a few other diseases, there seems that there may be some biologic or genetic component to it. And that's something that I'm really excited to explore moving forward, and I'll get into a little bit. And so this is data that Dr. Grant also presented, but most of our research comparing Black myeloma patients to other groups is located here in the United States, and race is self-reported. So it's generally Black versus white groups, and the researchers will just ask the patients, what do you identify as, and they'll mark down their race. But there's more and more discussion now about how race is a social construct, and it's not necessarily something that's objective that can be measured, whereas ancestry is something that can be measured. But regardless, research shows that we're diagnosed at nearly double the rate of white patients with multiple myeloma. We're diagnosed at younger ages, and we also are not offered these new or novel therapies, including transplant, as often as other groups are. As we've touched on repeatedly, and we'll get into that even more before this program is over, is just the lack of our participation within clinical trials. And something that's been very intriguing to me and something I'm hoping to study moving forward, as I talk about the biology, is that there seem to be similar rates of MGUS and also myeloma in African patients. They're very high, similar to what we see in Black Americans here in the US. And so it suggests to me that there might be a deeper reason besides just socioeconomics and access to care, and maybe that there's a genetic component. And so that's something that I'm looking forward to exploring moving forward, because there was a question about, do certain medications work better in Black people? Do certain medications work better in certain types of Black people? And I think those are still questions that need to be answered. And also I want to mention that we don't know very much about multiple myeloma in the Hispanic community or Native Americans. And so, as I think about studying the diaspora, it's important to remember that many Hispanics also share African ancestry, whether it's recognized or not. And incorporating genetics may help us figure out why Black people have such higher rates of diagnosis. And so this is a chart just to give some historical context, but and this is also something that Dr. Blue touched on extensively, but we've had tremendous progress over the last 10 to 15 years when it comes to our treatment options in multiple myeloma. And so this chart is actually outdated. It's from 2012, but it still is able to give some of that historical context. So as you can see on the left side of the chart, from melphalan and prednisone in 1962, over the next 30 years, we had a few more treatment options that were added, but they remain limited. But since the mid 2000s, we've had a substantial increase in the treatment options. And again, because this chart is old, all of the treatment options aren't even listed. But some of the game changers, like Dr. Blue mentioned, is our proteasome inhibitors like carfilzomib, immunomodulators like pomalidomide or lenalidomide. And then this chart doesn't even cover the anti-CD8 therapies like daratumumab, not to mention CAR T, bispecifics. So we have plenty of treatment options, and there's been tremendous progress. And so it's not just enough for us to make progress with new treatments. The goal is for patients to live better and to live longer. And it seems like we're doing that. With these new or novel therapies, overall survival is increasing, as we've touched on repeatedly. In the 90s, the average survival for a newly diagnosed myeloma patient was only about 3 years, which is very different than today's paradigm, where some patients are living as long as 10 years and hopefully even longer. And so I think, having more treatment options and having better outcomes is just a sign of the recent progress we've made. And for me as a trainee, someone early in my career trying to decide what my area of interest will be, having a disease that not only affects us disproportionately, but we're making progress, that's exciting to me. And it's a reason why I wanted to be in the field. And so, just to kind of summarize, and we'll open the floor for questions afterwards, but I can't deny that we've made significant progress. We've touched on that for the last 2 hours. We have many new therapies and patients are living longer, but there's still more work to be done. And so, as Dr. Grant mentioned, recruiting Black patients to clinical trials, and Dr. Blue mentioned as well, it's something that it has to be done. The US government and pharmaceutical companies are spending a lot of money to study new drugs, and it's important to know if they work on the entire population. It's hard to know that a new promising treatment works on Black people if we're less than 5% of the trial participants. And so I'm hopeful that, as we have more community outreach and improved language, that we can start to have more of us on trials. But I will say I'm pretty encouraged by the fact that this topic of clinical trials is being discussed more and more, not only among patient groups, but among community physicians thinking about clinical trials. And I think that's a direct result of programs like what we have going on right now. I also want to say we need more Black myeloma doctors. Again, that's a part of the reason why I wanted to go into this area, this field. Black doctors account for only 3% of the physicians in hematology and oncology. So I'll say that again, of physicians who practice hematology and oncology, only 3% of them are Black. But we know that research shows that having a physician who comes from a similar background or similar places you usually leads to better outcomes. And I think we should be pushing for similar representation within myeloma, where the percentage of Black myeloma doctors is in line with the percentage of Black myeloma patients, and we're just not there yet. And then the last piece I'll touch on, which is my first bullet point and what I'm most interested in, is research or work focusing on the differences between Black people. Dr. Blue mentioned that we're not a monolith. I went to Howard University for undergrad, and I remember coming back home like during my breaks, and people would ask me, "Oh, what's the biggest lesson that you learned at an HBCU?" And I'll tell them is that I didn't realize how much diversity that there is among the Black population. And so I'm hopeful that taking a comprehensive look into myeloma and people of African descent could unlock the answers for why some of us are more likely to get myeloma than others, and could also hopefully identify some therapies that might be more likely to work in us. And so, as I was exposed to a lot of these topics during my medical school and residency training, it really started coming together for me where I was thinking someone is going to have to do this work, and why not me? And so that's the big reason why I'm here on this call and why I'm putting my time in to become a specialist like Dr. Grant and Dr. Blue. And I guess just to put it in a simpler way, this is a cancer that disproportionately affects Black people. So by choosing to be a myeloma specialist, I get to build long-term relationships with Black patients who have a cancer that there are increasing treatment options available for. And so not only do my Black patients get to do better because we're making so much progress, but I get to do research focusing on us and why we're having much higher rates of diagnosis, and hopefully we can determine some treatments that work better for us. And so from my perspective, it really doesn't get any better than that. And so with that, I'll close and kind of open the floor for questions. I would love to keep the discussion going similar to how we had before. I know there were some more questions.
Awesome. Thank you, Dr. Ayo. Did I say that right? Did I get it right?
That's right.
Awesome. Awesome. And Chicago bound there. I remember you shared that with me. So thanks for being here. And thanks for making that choice to come on and work in the field of myeloma. For all those reasons that you stated, we are grateful. And we're expecting some great work from you, Dr. Ayo. So thanks for joining us here this afternoon. Do we have, let me go through. We got some questions coming in here, and I've gotten off of my thing here. While I'm looking up those questions, I want to go back. There was a question in the chat that I didn't get to ask there. Dr. Grant, why do you think it is that older Black myeloma, people with myeloma don't want to seek treatment, or there's that hesitancy there?
Yeah, I was playing some chat. I was putting stuff in the chat as I was going through, and so I put an answer in there, but I'll say also here. So I think a big part of the reluctance really is one, as you get older, what we've found and others have found in other cancers is that older adults tend to value quality of life over quantity of life. And oftentimes when I'm confronted with someone who's at the extremes of age, usually in their 80s or pushing on to 90s, the biggest concern is about potential side effects. How is this going to affect my quality of life? How is this going to affect my function? And there's always this needing to weigh, what their life expectancy realistically is at this point, depending on their age, and whether or not getting treatment will either hasten that, which sometimes that's their perception because they may get really sick, they get complications. So I really think that it is driven by this fear of worsening or declining in those two domains. And then I think the other thing is sometimes, and not everyone with multiple myeloma comes in and they're terribly sick, meaning that they don't have a lot of bone pain. This may be something that is picked up incidentally. And sometimes for an older adult, if they're really not having a lot of symptoms as a result of the disease, it could be really challenging in the conversation to encourage them to treat something that really, in their perception, isn't bothering them. The way that I answered this in the chat also was to say that I tried to emphasize that, without treatment, that multiple myeloma is a very debilitating disease. You can get all these other complications. And I always want to say that, even if we make a decision to start treatment, and again, speaking about the older adult, it doesn't mean that we have to continue with treatment. We stop, we reassess, we see how they're doing, what their symptom burden is. And then if things aren't working out, we think about, can we reduce the dose? Can we change the schedule? And then if that doesn't work, and we come to a shared decision about whether or not stopping treatment is the appropriate thing to do. So I hope that answers the question. It probably gave you a little bit more detail than maybe what you were looking for.
Thank you for that. So Dr. Ayo, I want to thank you for the great explanation of the African-American dysphoria. Just seeing that on the screen and having a explanation of how things came to be. Thank you for showing us that. We do have a comment here in the box. Tell your partner hi from the child of a Grenadian mother. Am I saying that right? Arnold Harris family. Okay. Thanks for that comment. There's one here. There's a clinical trial for smoldering myeloma in Houston, Texas. Okay, I think somebody was just giving us information on that. It looks like that's what that's about. We had another question here. I'm just going to read it. It says, I was diagnosed September 2018, had my transplant May 2019, recovered well, maintenance on Revlimid 5 milligrams. Since 2 months, my M spike is going up. Other blood results show good. CT scan showed no bone problems. Doctor said it is not working anymore and we'll start another treatment. It looks like they're looking to start with daratumumab. Have been meeting, the nurse said the immune therapy. How would you advise this person? I mean, obviously, you're not their doctor, so you can't give them, anything specifically, but what would you say to this patient here? Looks like they live in Holland.
I would say two things. I would say, number one, I would say, typically the dose of Revlimid in the maintenance setting is about 10 milligrams. So with being on 5 milligrams, that is a little bit of a lower dose, but the right dose of Revlimid is the right dose that works for you. Okay, but just know that it is a little bit lower than what we would traditionally do as our standard maintenance. The second thing is that there's different types of relapses. The first type of relapse is basically where you have a new bone lesion or some new, like myeloma, what we call defining event, where the kidneys are shutting down or that, things are really kind of creating a problem. Okay, those really need kind of fast acting, rapid treatment because that bone is now fractured, or some people have it in their spine where it pinches a nerve and they have trouble walking. So there's things that need to happen emergently. But then there's what they call a biochemical relapse, where you watch the number and you watch the number and you watch the number, and then you know that basically it's going up, but you have a little bit of time. So then you have some options. You could potentially give a higher dose of Revlimid, since again, the dose of Revlimid was a little bit on the lower side. But then, your doctor may decide to add an extra medicine. So it sounds like they decided to add daratumumab. That's not necessarily wrong to do, to kind of make sure that, whatever benefit that we do get from this kind of rising number, once it goes back down, it can kind of be sustained for a longer period of time. And so I would just say that that's not an inappropriate thing to do. But again, like I said, if I don't know your situation, but I would just say that I would imagine that it will come with a higher dose of the Revlimid. And I'll just say this as a side note, is that typically for myeloma, we do what they call multimodality therapy, meaning that it's very uncommon for somebody with multiple myeloma to just be on one treatment. And if your doctor is typically recommending one treatment, you may want to question that a little bit and just say, well, why not more than one? Because we know in myeloma, a lot of the studies prove that if people can be on 2, sometimes 3, sometimes even 4 drugs, really the results are better. So that just may be something that you want to look into. And again, I don't know how things work in Holland. I think you said this person's from, but we always recommend people to get a second opinion from a myeloma specialist if your doctor isn't considered to be one of those.
Thank you for that explanation. Anything that either of your other doctors, Dr. Ayo, Dr. Grant, would you like to add to that?
No, I completely agree. I think, overall it's hard on these things to give absolute medical advice, but I would second what Dr. Blue mentioned, especially about single agent use in multiple myeloma. We're up to using 4 drugs in the upfront setting and also in the relapse setting. So, I would also question if somebody recommended just a single drug for relapse.
Thank you, Dr. Grant. Dr. Io, are there efforts across the country's medical education institutions to encourage more Black physicians to consider hematology oncology? Good question.
I think there are, when I look at some of the programs available now for medical students and residents compared to 5 years ago when I was a medical student, it does seem like there are more. They're primarily coming from our professional organizations, ASCO, which is our clinical oncology organization, and ASH, which is the major hematology group. They both have significant diversity efforts. And I do think that those efforts increased after the racial unrest and the protests that we had associated with George Floyd's killing in 2020. And so, across the board, not only with corporations, I think we're seeing it within medicine that everyone's trying to do their part, or at least make it show like they're trying. I think, when it comes to hematology, oncology, we're just trying to get more Black doctors in general. And I think from there, we're hoping that it kind of spills down the pipeline to hematology, oncology. But one thing that was very helpful for me being interested in myeloma was just the education about disparities. And that's something that I think we can do a much better job of. Someone mentioned earlier how, even primary care physicians often don't know that myeloma disproportionately affects the Black community. There are a lot of things we know that disproportionately affect us, but at least when we talk about cancer, most people generally know that prostate cancer affects Black men more than the average American. And I think with Chadwick Boseman's death just a few years ago, we're recognizing how we're being diagnosed earlier and earlier with colon cancer. It will be nice when we get to the point where people are recognizing myeloma as one of those diseases. And I'm hopeful that more physicians will be interested in more Black physicians will be interested in the field once this is more common knowledge.
Awesome, thank you, thank you. And Dr. Io, Courtney has a question here. This is a good question. Growing up in Jamaica, I had no knowledge of this disease. How long ago was this disease identified as a type of cancer? And is there any data on instances of this disease among the dysphorias?
And I'll defer to my colleagues who have more experience if they have any more insight on the history. But I think we've been recognizing myeloma as an entity since at least the early/mid 1900s. I think I remember like the 1940s and 50s. But there are even historical notes from physicians hundreds of years ago where we think like, oh, maybe that was myeloma. So it seems like the disease has been around for a long time, but in the past 20 years or so, we're making significant advances. I have not seen great data on the diaspora. Most of the data that I've seen on Black patients is based here in the US, with a few small studies coming out of Africa, in particular Ghana, which is what got me so excited about studying the diaspora in general. But I'm hoping to do the work that you're asking for.
Thank you. Dr. Grant or Dr. Blue, anything on that?
Yeah, oh, sorry, go ahead.
No, ladies first. No, I'm
I would say, I agree. There's a kind of, I don't want to say famous, infamous diagram that is shown from, I believe it might have been in the early 1800s, potentially, or even 1900s, but it basically shows a woman who ultimately died of this disease, which they believe was ultimately multiple myeloma. It shows really debilitating or deformed bones. So this disease has really been around for a long time. I think it wasn't really probably until the 1900s then that it became like people were able to tie together the finding of the abnormal protein and then the bone lesions, and then kind of bringing the entity together. I don't remember the exact year when we really started to see, multiple myeloma as a disease. But one of the things I wanted to also highlight here is that I too am from Barbados, in case I probably should have said that at the beginning. And I know that there are efforts to try to look at this awareness from a myeloma perspective, at least, because I was just invited to participate in an event there in September. But to try to start gathering numbers across the Caribbean about the number of cases. And those of you who have a Caribbean background, you know how difficult it is to do anything, like gathering case counts, especially across countries. But I know that there definitely is interest to get better reporting about this disease in the Caribbean.
Listen, I would love to go to the Caribbean. I just have to throw that out there. I'm from Florida, so I'm not from the Caribbean. I don't have any background in any of that stuff. But if you're going and we're trying to help myeloma, let me know. I'm happy to be there.
All right. Thank you, Dr. Blue. Oh man, I want to take just a moment to thank all three of our speakers, thank the audience, thank you guys for some amazing questions, very good session. I learned a lot and I am really inspired. I encourage you, if you haven't already done so, just take a moment to stop by our website, blackmyelomahealth.org. Each of these doctors is listed in our specialist directory. So if you have an interest in connecting or going for a visit, please find that information there. So as I want to make sure I give the doctors, you guys have any closing statements? I don't want to close out without giving you an opportunity to, have some closing remarks there. So go for it.
Ladies first.
All right. Well, I want to say that this has just been an absolute joy for me to be able to come here today and just to share and to hear others just talk about multiple myeloma, especially in the chat. Thank you so much for your interactions. Thank you to HealthTree and Black Myeloma Health in particular for the opportunity and for just creating this space that we can come and talk about these issues that primarily affect the Black community. And also thank you to my esteemed panelists. And now I know that Dr. Blue is very interested in going to Barbados to talk about myeloma for the Awareness Month in September. So thank you.
Thank you, Dr. Grant.
I'll just say from my standpoint, I just want to let people know that, to have 3 Black myeloma doctors in one room, on the virtual platform, this isn't unheard of. Okay. So I want people to know how rare of an event this is. And so just know that we do this because we care. We do this because we really want to make sure that people know about the disease that we see every day, and, it's okay if your doctor doesn't know, but what you would need to do as a person, especially a person of color, as a Black person, is get to somebody who does, okay? Whether that's be virtually, especially what they call Zoom visits or telehealth, okay? If you feel uneasy or if you just want to check, one thing we don't do as a people, we be so loyal. And sometimes we feel like the doctor might get mad. No. This is your life, okay? Get a second opinion. Just have somebody double check like me, Shakira, Dr. Fatoki, somebody just to say, yeah, your doctor's actually doing the right thing. You'd be surprised how many times we catch things and like, I wouldn't do that, and especially of us who see it every day, we kind of know and we can kind of see things in the future because we know kind of where things are going. So that would be my biggest thing is, to sign up for clinical trials if they're available and to try to get a second opinion, because again, that's something we don't do as much as a community. And I appreciate y'all for listening to me. And, I do kind of make light of things sometimes, but myeloma is a very serious thing. And I just want people to know that it's just because we care.
Yes. Thank you. Thank you, Dr. Blue. I'm glad you were able to hang on with us. Thank you.
And I'll close out and say it's a team effort. We need organizations like HealthTree. We need Black physicians taking our time to participate in programs like this. And we need patients and advocates and coaches to do your part as well. So, this is a team effort.
Awesome. Thank you. Thank you guys for joining us this afternoon and giving us so much to have hope in. We need that as Black myeloma patients, the Black myeloma community. So thank you. Now, I do want to say, as you're leaving the session today, I would definitely appreciate you taking 2 to 3 minutes to fill out a brief survey about your experience during today's events. And I invite you to join us next month for a session on how to spread the word about myeloma in our Black communities. Many of you know next month is Myeloma Awareness Month. And we often talk about spreading that word and spreading awareness. So we're going to tell you some ways that you can do that. We're going to hear from Marsha Calloway Campbell, the Black Myeloma Health Initiative Director at HealthTree. And we're also going to be joined by Matt Murtha from Janssen, and he's going to be talking about the That's My Word campaign. So I hope to have you all back here with us next month. Now, there are some other HealthTree community events that are coming up that you may have interest in participating in. Later this evening at 7 o'clock, the MRD chapter is going to be meeting. They're going to be talking about, is MRD negativity the end goal? Understanding when and why that's important. On Tuesday, February 28th, the Florida Myeloma Community Chapter will be meeting. And they're going to be talking about how to talk to your friends and family about your diagnosis. On Thursday, March the 2nd, the HealthTree Moves for Myeloma chapter. They will feature myeloma patient Keith Gurnessy, and he's going to be sharing about his journey. Start slow and keep moving with myeloma patient Keith Gurnessy. The link to sign up for those events and even more events that I haven't mentioned today is found at the bottom of the slide and will be sent out to you in a follow-up email within 48 hours after today's event's completion. As always, I want to thank our sponsors, without whom this would not have been possible: Bristol Myers Squibb, GSK, Genentech, AbbVie, and Amgen. And thank you all for helping us build a strong Black myeloma community. I appreciate you and hope you enjoy the rest of your day. Bye-bye.